हाय संदीप,
Yes, sir.
कैसे चल रहा है? ऑल वेल?
Yes, sir. Good, sir. Fine, sir.
Still at Nashik, right?
Yes, sir.
Okay.
How are you, sir?
Good.
Yes.
कहाँ से पढ़ा फिर? गाइडलाइंस, डेविटा?
EAU पढ़ा सर और NCCN पढ़ा सर.
Only guidelines? Yeah.
थोड़ा देविता पढ़ा सर.
तो SAKK phase 2 SAKK ट्रायल क्या है? सेमिनोमा 2A ट्रीटमेंट. देख लो.
We ate one cycle of carboplatin, sir.
And what is the conclusion? चलो देख के बताओ, टाइम है. आज प्रेजेंट करने वाला है ना?
Yes.
ने ज्वाइन किया कि नहीं पता नहीं.
Give Perry now.
नौ बज गया, स्टार्ट करना है.
Good evening, Ganesh.
ट्रायल करून घ्या आधी.
Yeah, Ganesh, we wait for 5-10 minutes. Let some people come and then we start.
चलेगा, लेकिन सर चालू करते हैं, 9 बज गया एक्चुअली.
Yeah,
Because we start more late.
9-10 को चालू करते हैं हम लोग. Let अपना ये ज्वाइन किया कि नहीं किया?
None था.
Good evening, Ganesh bhai, Gaurang sir.
Hi, how are you?
All good.
मीटिंग रिकॉर्डिंग पहले से ही चालू हुआ है. उसको बोलना चाहिए कि बाद में चालू कर when people join. नहीं.
Who is answering today?
Sir, one is me, Devraj, surgical oncology resident, sir, third year in the Sri Shankara Cancer Hospital. Previously, sir, I am with the Dr. Sultan Pradhan, but last year hospital had been shut down, so I'm relocated here. Another one is the Sandeep. He is also my batchmate, but he is relocated at the Nasik, at SCG Nasik, sir.
Okay, so Devraj and Shubhneet, two of you are
Sandeep,
answering.
Sandeep, sir, Devraj and Sandeep, sir.
It's
Acha, Sandeep. Okay, okay. And one of you have got some case presentation also, correct?
Yeah, yes, sir. I have one case presentation. If we have time, then I will present. I send it PPT to the Swastik. He will share the PPT, then I will tell, sir.
Okay, okay. Gite sir has joined, na?
Sir, good evening, sir. Join, sir.
Good evening.
Fine.
Good evening.
Good evening, sir.
Yeah,
Good evening,
good evening. Hiren, good evening. So in 1 minute we start, and then
Yes.
whoever will join later on, that's okay. I think Pankaj is going to join little late.
And Mahendra is busy in some emergency.
Yeah.
Hello.
Hi.
Hello.
Yeah, good evening, Anil bhai. Dr. Udaydar, good evening.
Hello.
Yeah, we can hear you.
हाँ हाँ गौरंग मुझे एक पूछना था डॉक्टर गणेश बख्शी को पूछ सकता है कुछ है
Yeah, please, go ahead.
हाँ डॉक्टर गणेश can you hear me हाँ when we were actually students there was one concept that if you in the case of RCC if you do palliative or whatever cytoreductive surgery the secondaries they regress so is there any means any meaning in that or it's a just it was just hypothesis it is proved double blind control study
It
was
was a
done
hypothesis. It has been
Huh?
seen very rarely. It was a hypothesis seen very
Huh.
rarely.
Ha.
And we don't know based on the investigation present at that time, was it really
Yeah,
like or was
Exactly.
it a fallacy of the
Yeah.
investigations done at that time? If an X-ray
Yes,
was showing lung met and then later on it was not showing, we really don't know whether it was reproducible.
Yeah. So not proved. Yeah.
Today's investigations, at least we don't see anything like that.
Yeah. Thank you.
Yeah, we are just waiting for Dr. Swastik to start the PPT. Swastik has joined now. So can we start? Ganesh, Dr. Gite, Hiren.
जल्दी चालू करते हैं.
Yes, sir.
Next time we'll request.
Yes, sir, we can start.
Earlier, sir.
Okay, Swastik.
Good evening, sir. Good evening, on the faculty member.
Swastik, come near to the mic and speak little
Yes, sir.
louder and little clearly.
बात करो, आवाज
You know?
जोर से आनी चाहिए.
And don't go very fast whenever
Okay,
you are reading something. Okay?
Okay, sir. Okay, sir. Should I start, sir?
Yeah, you can start.
Yes, sir. So the first case is a 32-year male engineer by profession presented with complaints of swelling in the left hemiscrotum for 3 months.
Yeah, so when such a, who is answering now?
Myself, Devraj.
Devraj and Sandeep are answering, correct?
Yes, sir. Yes, sir.
Yes, sir.
Yeah, so to either of you, when the what is the importance of such a hypertension or blood pressure in urology? What are the relations? Forget about in general.
Sir, one of the cause of the hypertension is the renal.
Yeah, so you can say either renal or it can be other than renal causes. So what are the
Yes,
renal
sir.
causes?
The renal causes like
Renal artery stenosis.
yeah, renal artery stenosis, renal parenchymal disease, some, and
Can't hear you actually.
Yeah, sorry, I just got confused. Okay, this is a different thing. Complaints of swelling. So, okay. Now, what are the questions you will ask in this?
sir, we will ask it. This is a 32-year gentleman. If he had that swelling in the left hemiscrotum, is the painful or painless, and ask if it's the sudden onset or insidious onset. Is it either married or unmarried? If the married, he had the complete the number of the children, and either he had the urinary complaints or not, and he has a history of the fever and trauma. And, others also.
Associated pain we will ask, sir. We'll ask any history of fever associated with chills and rigors, any history of trauma, whether it is a sudden onset or an insidious onset. Any past history of surgeries we'll ask.
Talk fast. I mean, don't waste time in history.
Okay, Swastik, go ahead.
Sir. Yes, sir. So the swelling was gradually in onset, was increasing in size over the last 3 months. It was not reducible on lying down. There was no history of increase in size on cuffing or straining. There was no complaints of skin changes, discharge associated with the swelling. There was no history of any trauma to scrotum. There was no history of similar episode in past. There was no history of fever or cryptorchidism. No complaints of penile discharge, dysuria, or lower urinary tract symptoms. There is no history of diabetes, hypertension, bronchial asthma, or hypothyroidism in this patient. And patient is married for 2 years, has no children, has no addiction, sleep and appetite are normal, bladder is normal, family history is not contributing.
Devraj, how would you ask history of cryptorchidism?
Sir, we will ask the history of the cryptorchidism. We will tell to the patient if patient having the cryptorchidism may be either unilateral or bilateral. If patient having the feeling of that empty scrotum.
I'm sorry, your voice is not clear, but somebody else is some time pass in the background.
Okay, sir. Okay. No, sir, I'm alone only. Sir, I will ask to the patient if there is any history of the empty scrotum with any side, either any side there is a feeling of the empty scrotum of the crypt orchid inside.
Okay. ठीक है.
So should we go to examination, general examination?
So what, Sandeep, what will be the significant family history? You guys have written, right? Heading family history. So in the case of testicular, whatever history suggesting testicular mass, what is significant family history?
Sir, in the family history, there is the positive family history, especially in the first degree relatives. There is a 2 to 3% relative risk, higher relative risk as compared to the general population. They might be developing the testicular malignancy. Especially in the brother as compared to the father and children.
Okay. Can we ask history of Klinefelter or something?
Yes, sir. Yes, sir. We will ask, sir.
Good.
Coming to general examination, patient was conscious, oriented and cooperative in nature, was examined after prior informed consent. Pulse was 90 per minute, BP was 130/70 millimeter of mercury, febrile, saturation was 99% of room air, Karnofsky score was 90, no pallor, icterus, sinuses, clubbing, edema or lymphadenopathy, no gynecomastia on examination. Per abdomen examination, after proper informed consent, patient was exposed from nipple to mid-thigh in a well-lit room. On examination, on inspection, all quadrants are moving equally with respiration, no abdominal lump, no scars, dilated veins were seen, all hernia orifices normal. On palpation, the abdomen was soft, non-tender, no obvious abdominal lump was palpable, all hernia orifices normal. On percussion, normal liver dullness was present. Auscultation, normal bowel sounds were present, no bruit or venous sum was present. And on rectal examination, no fissure, fistula, prostate was grade 1, firm, non-tender, rectal mucosa mobile, and no blood was seen on the finger. Coming to local examination, on inspection, right hemiscrotum appeared normal, a visible swelling of size 7 into 5 centimeter, seen in left hemiscrotum, no skin changes, no erythema or discharge seen. On palpation, on the right side, testis was not normal. On left side, the temperature over the skin was normal, firm, smooth, non-tender testicular swelling of 7 into 4 centimeter was palpable in the left side. Testes were not separately palpable. The swelling was not increasing on coughing or straining, not decreasing on lying down. Get of the swelling was present, skin over the swelling was mobile, fluctuation test was negative, and translucency was negative.
Okay, from the history and examination, now what will be the differential diagnosis that comes to your minds?
Sir, this is a 32-year male, sir, married male. He having the no children. He had the sudden onset of the scrotal swelling. In basis of the history and the examination, it favor in case of the testicular malignancy left side, sir.
So what are the causes of sudden increase in the size of the swelling?
Sudden increase is either may be due to the trauma or any acute inflammation.
Okay, fine. And if it is a malignancy, what will be the cause of sudden increase in size?
Any hemorrhage in the malignant part, sir.
In the swelling, in the malignancy.
Yes, sir.
Okay. So now, after this history, what will be the differential diagnosis?
Sir, my differential diagnosis will be first diagnosis will be a malignant testicular swelling, sir, of the left hemiscrotum. Because in the history there is no history of fever, no history of trauma, and no sudden onset of the swelling. I would not like to give any other differential diagnosis, sir. And the in examination also the points it's a non-tender testicular swelling and it is inseparable from the testis, and it has no not increasing on coughing and straining. I would like to keep as a malignant testicular swelling, sir.
Okay. So Ganesh, in exam, if they say only this one diagnosis, it is okay, or they might have to take one or two, like any other?
तो बोलना चाहिए मतलब अभी तक तो there is no great positive history except for young patient having probably a painless swelling. ये palpation में firm smooth बोला है, not a hard.
So it can be like a tense. He might not have noticed so earlier, but it might be a tense, even tunica vaginalis hydrocele also, correct?
But sir, translucency is the negative, that is not favored.
So what are the causes of translucency negative?
Sir, if there is hemorrhage inside these things.
So it may be hemorrhage, it may be a chylocele, it may be a pyocele, it can be because of the thickened skin, it can be because of the thickened sac.
Yes, sir.
So many causes.
Whatever has been written here, palpation, there is one sentence here, 1 minute, about non-tender testicular swelling. So we have a different word for that, loss of normal testicular sensation in malignancy.
Yes, sir.
Which is probably different than what is written here, non-tender testicular swelling. Tender, non-tender is in fact inflammation.
Yes, sir.
So loss of normal testicular sensation also matters.
Yes, sir.
You may have hydrocele, but I can press it, it will cause pain. Okay. And then I don't know, matlab, we can probably add tuberculosis or something, but tuberculous testis will have epididymal sinuses at times. And then young patients, so lymphoma cannot be discussed here.
I think the two differential diagnoses will be, one is the malignancy, and second will be, it may be a tense or
Chronic
hydrocele. Yeah, long standing means, it may be sudden increase. He might not have, many a times it happens. We are also surprised why suddenly patient has come and he says only 3 months or 6 months of history, which is not possible otherwise. Right. The only thing is he might have noticed so just 3 to 6 months back.
Okay.
Fine. So we'll go ahead. So what next? Now what you want?
You
want to operate him directly? What do you want to do?
No, sir. As a continuation of a clinical examination, I would like to do an ultrasound, sir. Ultrasound sonography of the sonography of the high frequency sonography, sir.
Only sonography?
Doctor नहीं करना है तुमको. What is the point in doing only sonography?
Sir, first I will do a sonography. After that, I will do tumor markers, AFP, LDH, and beta HCG.
And you don't want to do anything for the simple test like urine and like CBC, creatinine, basic test?
We want to work up.
This patient, understand, this patient has come to your OPD.
Yes, sir.
Yeah.
Fine. So,
yes, sir.
In your OPD, what are the tests you are going to ask for?
Sir, in the OPD, when we see the patient, so first examine, after examination, we will do the investigation like that, first to support the diagnosis, and then to the confirmed diagnosis, then to the stage of disease and routine investigation, sir. Routine investigation like CBC, RFT, LFT, and ECG, chest X-ray, depending on the.
Yeah.
For the supporting diagnosis, sir, we will do the tumor marker and USC scrotum plus abdomen with especially high frequency USC is scrotum, sir.
Okay, fine. So show them the report.
Sir, the hemoglobin was 12 gram per deciliter. TLC was 6,600. Platelet was 3,21,000. Creatinine was 1.02. Urine routine microscopy was done. It showed RBC 1 to 2 per high per field. WBC 0 to 2 per high per field. No cast, no bacteria, no crystals. Alpha fetoprotein was 1.24 within normal range. Serum LDH was 633. Slightly raised, and beta HCG was 6.546.
So what are your comments on the reports?
Sir, on the basis of the reports, sir, that routine investigation are the normal, but on the tumor marker, alpha fetoprotein also normal. LDH is the raised, sir, because normal value is the 100 to 300 approx, and beta HCG is the minimally raised, because normal value is the less than 5. So is the most likely we have the possibility of both seminoma as well as non-seminoma, but maybe seminoma component also because of the this range of the beta HCG can raise in the seminoma component also.
So now you are telling me all these things.
But we do the other
Let us-
investigations.
Let us first discuss about the three markers. You tell me first what is the half-life of the three markers? What is the importance of this in different conditions?
The half-life of the LDH usually 24 hours and beta HCG is the 24 to the 48 hours and alpha fetoprotein is the 5 to 7 days. So usually the tumor marker we will do in the both pre-orchidectomy and post-orchidectomy, but in the staging we included only the post-orchidectomy level markers. So usually the post-orchidectomy we will repeat the tumor markers after the approx 5 half-lives of the 5 half-lives of the tumor marker. So that's why like LDH and beta HCG we will repeat after the 2 weeks and alpha fetoprotein after the 4 weeks of the orchidectomy. The persistent level of the tumor marker after the orchidectomy may be suggestive of the metastatic disease present in the
Yes, can you mute whoever is talking in the background? Hello.
Hello. Yes, sir.
Hello.
Yeah.
Yes, sir.
So you are just telling us the you are not telling us the importance of the tumor markers in the malignancy, testicular malignancy. What is the importance of that? You are just telling us about a follow-up and other things. How you are going to follow up. That comes later on. No? Now, in this case, if these things are not increased, then how we are going to follow up?
And then we will share along the tumor marker, we need the other investigation, also sonography, scrotum,
No, first
abdomen.
tell me about the tumor markers. What are the different diseases? And in which disease it increases, in which disease it means, in which case it's not going to increase.
Okay.
In a pure seminoma, alpha fetoprotein will be normal, sir.
And beta HCG always is increased?
No, sir. In 20% of the cases, it may increase. Sir. Otherwise,
So in 80% of the cases, you may get a normal report.
In 20 to 25% of the cases, sir.
Now you are saying that alpha fetoprotein doesn't increase, correct?
If in a case of seminoma, alpha fetoprotein will be normal, sir. If there is no other component.
Yeah, and what about beta HCG?
Beta HCG, if beta HCG will be elevated in about 60 to 70% of the cases, sir. Or otherwise 30% of the cases will be normal, sir, in a pure seminoma.
Okay, fine. So that is number one.
Yes.
Then which other disease? You keep on telling us, no?
Yeah.
You have got a classification or not?
Yes, sir. S1, depending upon the S1, S2, S3, sir.
No, classification of testicular tumor.
Yes, sir. WHO classification is with the germ cell neoplasia in situ underlying and which is not related to germ cell neoplasia in situ, sir. Under germ cell neoplasia in situ, it is seminoma, sir. Pure seminoma. And non-seminomatous tumors like embryonal carcinoma, teratoma, choriocarcinoma, sir. In germ cell tumors, neoplasia in situ, not dependent on in situ spermatocytic tumors, and also the yolk sac tumors, sir. And other tumors like sertoli cell tumors, Leydig cell tumors, sir. And neuroendocrine differentiation with neuroendocrine differentiation tumors, sir.
Fine. So now tell us that you in seminoma you said what are the criteria? Means
Yes.
alpha fetoprotein not increasing and beta HCG in 60 to 70%. Now tell us other which are the
in non-seminomatous tumors, sir. Alpha fetoprotein will be elevated, sir. And LDH is a component that it will be elevated in most of the cases, sir. In most of the cases, if in a case of a choriocarcinoma component is there, then the beta HCG levels will be elevated, sir, in a non-seminomatous component.
and alpha fetoprotein and beta HCG will be increased both in which conditions?
In yolk sac tumors, sir.
Mixed germ cell tumor, not
Mixed germ cell and yolk sac tumors, sir.
Actually, till time you are presenting like MBBS student, and I am totally unhappy with your both of your presentations. Because if you are suspected a testicular mass, then you should have 2 to 3 differential diagnosis and your history should be perfect. You should have definite plan. You should have definite investigation. You should know the levels in which thing which is increasing, which thing which is increasing. You are telling totally wrong. You have told classification also wrong. You have told testicular mass increase in beta HCG, alpha fetoprotein, LDH in seminoma. How much in seminoma? What are the finding in beta HCG, alpha fetoprotein, LDH? Bolo.
Sir, in the seminoma, sir, alpha fetoprotein is never raised, and beta HCG usually in the 30% cases the beta HCG raised. That also is the not too much level. Usually at the level of the 200,
Beta
300.
is raised only in 5 to 10% of cases, and alpha fetoprotein in 0 to 2% of cases. LDH is raised in 30 to 80% of cases. If you don't know, go and read it. Classification also, you have told totally wrong classification. Again, in history, the history should be very composite and very to the point. So if it is testicular mass, it is painless, painful, predisposing factor की history, then congenital syndromes की history, उसके बाद में antenatal history, उसके बाद में फिर environmental exposure की history, उसके बाद में फिर general examination में notes in the supraclavicular region, any abdominal lump, any bleeding gums, ये सब चीजें अगर तुम testicular tumor अगर suspect कर रहे हो, तो ये सब चीजें तुम्हारे उसमें फटाफट आ जाना चाहिए. अगर नहीं आए तो क्या मतलब है? स्वेलिंग पेनफुल है, पेनलेस है, सडन राइज है, अनडिसेंडेड टेस्टिस है, सर्जरी चाइल्डहुड में हुई है नहीं है, ट्रॉमा की हिस्ट्री है, लंप है, बायलैटरल लिम्फ नोड स्वेलिंग है, सीआरएफ की हिस्ट्री है, पल्मोनरी मेटास्टेसिस की हिस्ट्री है, या लोकली एडवांस डिसीज की हिस्ट्री पूछना है, मेटास्टेसिस की हिस्ट्री पूछना है, तो क्या हिस्ट्री में क्या पूछा आप? देखो मेटास्टेसिस लंबार पे, एंडिस्निया, हिमोप्टासिस, चेस्ट पेन, ये सब चीजें का कब पूछे? जॉन्डिस, हाइड्रोनेफ्रोसिस, पेडल एडिमा, ट्राउजर साइंस, ये सब चीजें आना है ना. अगर एमबीबीएस के जैसे प्रेजेंट करना है तो फिर उसको कुछ मतलब ही नहीं ना. लॉस ऑफ टेस्टिकुलर सेंसेशन है, चेंज ऑफ वॉइस, एक लिख के रखो ना. ये हर बार मैं वही बताते रहता हूँ, हर बार तुम वही स्टोरी करते रहते हो. तुम वो हिस्ट्री में ही अगर आधा घंटा खत्म कर दिए तो डिस्कशन होगा ही नहीं.
Okay. So let us go ahead with this thing. Dr. Gite, you explain them about the what is our as per the urological, what are the, because they are the onco students.
So, sir, there may be onco student, they may be urology student.
Yes.
Theory is same, na?
Correct.
here is same practical points are same, treatment is same. So the from which subject, which area they are coming, that doesn't matter. Choriocarcinoma again, only beta is increased in 100% of the cases. Alpha fetoprotein near about 0% cases में alpha fetoprotein increase होता है in choriocarcinoma. LDH increase only in the seminoma and teratoma. ये सब लिखा है book में.
Fine.
ठीक है, ये नहीं हो. So we'll go ahead.
Okay. Yeah, go ahead. Swastik, show the next thing. Swastik, we have done sonography.
Yes, sir. The sonography was done. This was a sonography film, sir.
Yes. Can any one of you comment?
Sir, it is a hypoechoic mass, sir. Solid mass with some calcification, sir, with increased vascularity, sir. This with Doppler is showing with increased vascularity, sir.
So if it is increased vascularity, then why it is not a chronic epididymitis or acute epididymitis?
Because he is not complaining of any pain, or there is no history of any fever, sir. And his urine.
How many patients of chronic epididymitis present with pain and fever? They present only with this. Why not with the syphilitic gamma? That is again presented with painless swelling.
Yeah, but sir,
So for that
epididymitis,
matter, we
they
have
have
to
the,
know all the practical points.
yes, sir. They also have the, sir, thickened epididymitis or thickened cordon examination.
Usually in malignancy, testis is enlarged except in choriocarcinoma. Testis is usually a nodular. It is firm to hard. Secondary hydrocele are usually present in majority of the cases. Loss of testicular sensations, and the epididymis is difficult to palpate. And the swelling is not separately palpated from the testis indirectly. So these are the local findings. Sonography, if there is increase in vascularity, then that is the why not epididymitis?
Yes, sir. It may be
Chronic epididymitis.
yes, sir. It may be possibility, but such a large testicular swelling in the epididymis to orchitis is the less possible.
So tell him the different points. Now, one, the size.
Yes, sir. One is
Correct?
the
Even if
size.
it is a chronic epidermolysis, it is not
Yeah.
going to be so high, large in size.
Yes, sir.
Second
Size
thing
and
is
hypoechogenicity.
It's an hypoechoic solid mass, sir, in which the in
Yeah,
epithelial orchitis there will be no not associated with large mass, which is a solid with a solid component, sir.
and what else? What difference you will see? It will be absolutely normal testis, and the contour will be normal. The surface will be smooth.
Irregular,
Surface is
recurrent. He will be having recurrent orchitis, sir.
then surface is the irregular, sir.
Yeah.
The
So say
contour
all
is-
these things. Huh?
Okay.
Fine. Okay. Read the report. First, second, go ahead.
Yes. So the USG immunoscopic region was suggestive of left testis was replaced by a heterogeneous hypoechoic solid moderately vascular mass measuring 8.5 into 5.6 centimeter with few small cystic spaces seen in the lesion. Left epididymis was not visualized. Right testis and epididymis appeared normal in shape and ecotexture. No evidence of focal lesion, hydrocele, varicocele, or torsion was there. And USG abdominal pelvis showed grade 2 to 3 fatty liver with no evidence of lymphadenopathy.
Okay.
So next, yeah, Ganesh, please go ahead. Now.
Yes, sir. I said okay. Matlab, the left testis is completely replaced with the
Correct.
tumor like manifestation.
Fine. So now after this investigation, you have come to some conclusion, some diagnosis. Correct?
Yes, sir.
As Dr. Gite also said that you have to decide what you are doing now.
Yes.
So after this, what investigation, or you want to go ahead with some biopsy, or you want to do some surgery, or what else, or any other investigation?
Sir,
What do you want to do?
on the basis of the history investigation, this is the 32-year male giving the left side testicular swelling. On the basis of the sonography, this is the soiled hypoechogenic lesion. Most likely the favor in the malignancy of testicular malignancy, and the USC abdomen and pelvis suggestive of the no retroperitoneal lymphadenopathy. And on examination also, abdomen is the soft, no lymphadenopathy and no supraclavicular lymphadenopathy. After the routine investigation, I will go for the left side high inguinal orchidectomy with the giving proper consent and also explaining the patient toward the fertility preservation for the, because patient having the not completed family history. So I will tell about the cryopreservation, semen preservation.
So now, one first question is that if the patient has completed his this thing, he has got 2 children and completed his family, you will not tell him about the preservation, sperm preservation?
Yes, sir, definitely I will tell.
Yeah, medical legally you have to say, na, tomorrow if something,
sir.
some catastrophe takes place and if he loses 2 of his children or his family, then what?
Yes, sir, I have
Correct?
to explain, sir.
So whatever it is, whether you'd say completed or not completed, you must explain that.
Yes, sir.
So that is number one. Second thing is, you want to do any other investigation before this? Why
Yes,
why
sir.
you don't want to do biopsy?
So because of that ultrasound is highly sensitive, approx 90 to 100% sensitive for the detecting the candid feature of the favoring in the testicular malignancy, sir. And the test.
Sir, I don't want to do a biopsy because one is due to I will change the lymphatic drainage, sir. And second cause is that I don't want a tumor seeding, sir.
Okay, so what changes it takes if you do the biopsy?
If it is a biopsy, then there is a high chance of going into the inguinal group of lymph nodes, sir.
If you do needle aspiration biopsy,
Yes, sir.
or if you do open biopsy through scrotum?
Yes, sir. Open biopsy through scrotum, it has a high chance of going into inguinal lymph nodes, sir.
And
You
coaxial
don't want to
biopsy.
do that.
Sir?
And if you do a coaxial true cut biopsy,
Yes, sir. We can do a coaxial true cut biopsy in very not sure, sir.
I'm not asking you indications. You said total violation happens. Bella, you said yes, then no.
But sir, we can do coaxial biopsy, but even the biopsy is because testicular malignancy as histopathology is the very heterogeneous. On the sometime on the basis of the biopsy we can't comment fully. So the minimum that biopsy in the usually in the patient favoring with the clinically and sonographically the testicular malignancy is the high inguinal orchidectomy.
Okay. Fine.
What do you want next?
So, yeah, what about a CT scan? You want to do a CT scan or you don't want to do a CT scan?
I want to do a CT scan, sir. CT scan, thorax, abdomen, and pelvis, sir.
Contrast, non-contrast?
See, contrast and
by chance अगर 2.5 है तो
sir, is creatinine is
बताया था ना इसने?
sir,
Creatinine 1, sir.
creatinine is 1.2, sir. So I want to be contrast enhanced thorax, abdomen, and pelvis, sir.
Okay. Why thorax? Why X-ray test should not suffice?
Sir?
Oh.
Sir, we can do X-ray chest, but because of the same sitting, we are already doing the CT abdomen and this CT abdomen and pelvis. So same sitting we can do that CT chest. Otherwise, we can also do the chest X-ray.
Suppose I do an X-ray. When will I do a CT?
Sir, we do the we will do the CT when there is the tumor marker level is the high, and on the CT abdomen and pelvis there are suggestive multiple bulky lymph node. Then
so high matlab what? S1, S2, S3, how high?
S3, sir, S3.
S3. ऐसा common guideline है क्या? S3
No,
tumor
sir. No,
में do a
no,
CT
sir. No, sir.
test. ये कहाँ लिखा
No,
है?
sir. No, sir. There is no
See,
such guidelines.
if an examiner
Especially
leaves
in
you
the
like that, and if you go on and on, so we'll have a nice discussion for 40 minutes, but marks नहीं मिलेंगे.
so there is no such
Yeah, this
guidelines.
guideline say
Uh,
X-ray can be done, but there are riders to that. The rider
Okay.
is very clear. If there are abdominal retroperitoneal nodes, then you obviously need a CT only of the chest. And
Okay.
European guidelines are very clear in saying they would suggest to do a CT chest, abdomen, and pelvis. And want to answer specific, you answer specific. But if somebody asks you, examiner can ask you why not X-ray. You have to explain the whole thing behind it.
Yes, sir.
If there are no only testicular swelling, maybe no nodes in the abdomen with CT, then you can go ahead with an X-ray chest. You can say then you are following different guidelines.
Yes.
Okay, so CT में क्या क्या पता चलता है generally? What do you hypothesize? How will CT help you?
Sir,
The,
CT will,
landing zones, sir. Retroperitoneal lymph
So
nodes.
this is left testicular cancer. So where will you expect?
Left, I will expert in the para-aortic, sir.
Para-aortic. Okay.
Yes.
Technically, what is landing zone of left? Main is para-aortic, and up to what are the limits?
Para-aortic, interaortocaval, then into the common until the up to the common iliac, sir. Left common iliac.
Until common iliac. Okay.
Yes, sir.
Okay. So
The right side also I will see, sir. But crossing is very, very rare, sir, on the left side.
Okay. And what else you will see on the CT?
I will see any other visceral, any other lesions, any other visceral mets, any pulmonary mets. I will see, sir.
and sir, we will see involvement of the vascular structure, aorta and IBC thrombus or other things.
Okay. IVC thrombus not so common, matlab.
Yes,
Right.
sir. But compression.
Unless the disease is so bulky that
Yes, sir.
we don't know whether the IVC is completely compressed or we are seeing a thrombus. ऐसा एकदम रेयर मत बोलना कभी एग्जाम में.
Okay, sir.
So CT plates दिखाए क्या?
Show them the CT scan.
Sir, we had a CT, pre-operative CT was done, sir, somewhere outside, and the patient came and a review was done, sir, from our side.
Yeah, show them. What was the
Sir,
review?
Sir, this was the report of the review, sir. The CT scan showed approximately 8.2 into 6.8 centimeter size heterogeneously enhancing soft tissue density lesion in the left hemiscrotal sac with non-separate visualization of left testis from the lesion. Suggestive of left testicular neoplastic etiology. Few small enlarged non-calcified pre-para-aortic lymph nodes seen with largest measuring 15 into 30 millimeter in left para-aortic region. Contrast enhanced characteristic could not be commented upon. Delayed phase images were not, as only delayed phase images are available. No focal hepatic skeletal or metastatic regions were seen. No left inguinal hernia was seen. Small left inguinal hernia was seen, sir. This was the review report, sir.
Okay.
Fine. So now after this report, now what next you want to do?
Sir, I want to stage the disease, sir. Pathological staging. I want to do a left high inguinal orchidectomy, sir.
So what do you mean by that?
I'll go to the. I will do an inguinal incision, and I will ligate at the point of the deep ring, sir.
Mm-hmm. And why you want to do that?
Because if I don't want to do any scrotal violations, sir, and I want to ligate at the point of deep inguinal ring, because there is a chance of first I will clamp the deep inguinal ring, double clamp, and then I will do the high inguinal orchidectomy, sir.
So two things. Why you want to do inguinal incision? Because as said, you don't want to violate the
Scrotum.
scrotal.
Scrotum.
Correct? Because it will change the staging. Number
Yes,
one.
yes.
Second thing, why you want to do first ligation of the cord? You don't want to touch the testis because you don't want to.
Spread of the some tumor
Village and
cells along
the
the.
tumor.
So you don't want any tumor to enter into the vessel and go there,
Yes,
right?
yes,
To
yes,
Yes, sir.
disconnect.
yes.
So you are doing high ligation. Okay. So
Mhm.
what are the indications? Will you like to do on the table frozen section?
Sir,
Sir, in this case, I don't want to do, sir,
Why?
because opposite testis is normal, sir, and no other any abnormalities in the opposite side testis, and he has no history of any other cryptorchidism or any other family history. So I don't want to do an frozen section for the malignancy, sir, for the diagnosis, but I may do for only for the margin of the cord, sir. If frozen section is available in the institute.
And Sandeep, if that margin of the cord is say positive in frozen, what will you do?
I will revise it, sir. I will revise and I will again.
So once you just said that you take the cord at the deep ring, so how many deep rings you will revise? I mean, how you will revise? You can explain us. So high inguinal orchidectomy is always done at the point where that
Yes, sir.
at the deep ring, a constant
Yes.
anatomical landmark. Hai.
Yes, sir.
So there is, we call it deep because it is deep ring.
Yes, sir.
Beyond that, if you want to extend the muscles and go inside along with the fascia, then we are going into the retroperitoneal component.
Yes, sir.
And technically, the cord margin is positive at the deep ring. Many times what we do is we are supposed to take a proline suture or not a linen because proline is blue in color. And we should probably transfix it by pulling the cord maximum so that that proline suture goes inside. And at a later date, sometime if in this case or when we are going to plan some RPLND kind of thing, we come to that point and remove that cord.
Okay.
That is what we do. So frozen, when do we send frozen actually in a testicular tumor or a swelling?
If you are contemplating if you are contemplating
On-table chemotherapy.
on-table chemotherapy, sir, if we are planning for the testicular preservation, the testicular sparing surgery, then we need to do the frozen.
There are indications of testicular preservation surgery. You
Sir,
are the
if
best. You yourself open the page of questions.
Yes, sir. Sir, if the testicular tumor size is less than 3 centimeter, especially in the solitary testis, or the patient having the bilateral testicular swelling, or the sonography is suggestive of the benign or intermediate like
All this with
lesion.
pediatric age groups, we do testicular sparing surgery.
Pediatric.
Slate plus pediatric age groups. That is the time when we do testicular sparing surgeries.
Sorry, I don't know, sir. In pediatric age.
So coming back, when will you do frozen? Actually, एक बोला तूने say testicular sparing surgery. What else?
and if in ultrasound the opposite testis is also looking abnormal, sir. If you're showing any microlithiasis or if any abnormality in the opposite side testis, sir.
So you will do frozen section analysis of the opposite testis also. So we are cutting two testes now. Sandeep, तुमने आंसर किया था तो क्वेश्चन तुम्हें.
And in the ipsilateral side, we do if you are not confident about the malignancy of the same site, sir.
Okay. I mean, I didn't understand much the logic of yours. So
Like
frozen
Chavasus
section-
manure, sir.
Huh? So frozen section is done at times when the tumor markers are normal, the sonography is indeterminate, and we are not sure if this is a cancer. Right?
Yes.
So in a way, indeterminate lesions is one indication for frozen section analysis for the testicular diagnosis, primary diagnosis. So ऐसे ही frozen section मत बोलो हाँ, please.
Yes.
The specific reasons for a frozen section. You must have seen so many high inguinal orchidectomies. ऐसे किधर frozen section हर एक में होता है? Cord margin के लिए होता है, नहीं होता है? Right, no?
No, sir. Yes, sir.
Yes, sir.
हाँ, ऐसे ही बोल के थोड़ी चलता हूँ. Okay, so what is the stage according to your CT and everything?
The CT,
It is-
this is the clinical and one, sir. And T stage, we will exactly tell after the.
Depending upon the
high
P
inguinal
stage, it may be 2A, sir. It will be on 2A. If the and tumor markers also we have to see, sir. And only nodal disease is N1, sir.
So tumor marker ka you tell me how you are going to do in the staging.
I will do post-orchidectomy, sir. After the 4 half-life, sir. After 4 weeks, I will repeat all the tumor markers, sir.
And what is the importance?
Sir, if persistent tumor marker after that 4 weeks, they may suggest of the metastatic disease.
आगे क्या करना है?
Sir, on the report of the that after the report of the that high inguinal orchidectomy, we will plan the treatment.
So, what is the place of radical inguinal orchidectomy in management of testicular tumor?
So that radical that high inguinal orchidectomy is the diagnostic as well as therapeutic in management of the testicular cancer.
हेलो गीते सर,
Sure.
तो वो चिवासूस मैन्योर का कुछ है क्या सिग्निफिकेंस?
नहीं नहीं ऐसा नहीं है. जो आप अगर प्रिवेंट वो स्प्रेड प्रिवेंट करने के लिए वो करना जरूरी है, और जहाँ पे भी आपको लगता है कि वो ब्लॉक करके बायोप्सी लेना है जरूरी है तो अदरवाइज ब्लॉक करके निकाल दिया तो चलता.
बराबर.
So the radical inguinal orchidectomy has, as you are told, diagnostic. What is my diagnostic? So it provides.
Diagnostic.
You will know the type of the tumor, sir, whether it is seminomatous or non-seminomatous tumor, sir.
So it provides a histology.
Yes, sir.
Yes, sir.
The
Histology,
staging.
T stage,
And
staging, sir.
it tells about the stage of the disease, sir.
Yes.
Pathological T stage.
Then therapeutic role.
Yes, sir.
If it is a localized disease, it is a treatment, sir, for that stage. If it's a localized
It's
disease.
a disease. It's a
It is
disease limited to the testis only, sir, and it is a therapeutic.
Seminoma.
Yes,
Or
sir.
Not able to hear, sir.
it is sufficient as a treatment in spermatocytic seminoma.
Yes, sir.
Yes, sir. Yes,
Or
sir. Yes, sir.
typical seminoma. Or
Yes, sir.
stage 1
Stage
seminoma.
1 seminoma, sir.
Yes, sir. Yes, sir.
Okay. Or it at least it will decrease the tumor burden.
Yes,
Yes.
sir.
Okay. So this is the role of radical orchidectomy in the management of testicular tumor.
Yes, sir.
So you have done a radical orchidectomy. So what after how will you proceed further? So you will ask for the report.
Report. Yes.
Yes, sir.
Histological report I will ask, sir.
Okay.
Swastik, show them the report.
So the patient event left high inguinal occluctomy, and the specimen. Actually, there were two reports. The first one report was this. The histopathology showed combined seminomatous and non-seminomatous germ cell tumor comprising of classical seminoma and yolk sac tumor. The distribution of tumor components was 70% seminoma and yolk sac tumor 30%. Tunica was not breached, no involvement of reti testis, no lymphatic emboli. The spermatic cord cut margin was free. So left high occluctomy specimen showed a seminomatous and non-seminomatous germ cell tumor comprising of classical seminoma and yolk sac tumor. Intact tunica and free spermatic cord margin. So all margins are free, no tunica breach.
It's a mixed non-seminomatous germ cell tumor, sir.
PT1, sir. This is PT1. PT1A. Hello.
Hello.
So this histopath was again reviewed at some center, sir. So
Tunica is intact, sir. It's limited only to the testis.
It's PT1, sir. PT1A, sir. No LBI and tunica intact.
T1,
In.
PT1, sir.
Hello.
Hello,
Yes,
sir.
sir.
Yeah. So now this is the report. Now next, what we want to do?
Now, sir, this is the sir
I will,
PT1A.
after 4 weeks, I will repeat the tumor marker, sir.
Tumor marker. Yes, sir.
It's looking as tunica is not breached and no LVI. All margins are free and it is only limited to the testes. I will categorize as PT1 and I will do the tumor markers after 4 weeks and I will decide for the management after 4 weeks, sir.
And after 4 weeks?
And after 4 weeks, sir, we will repeat again imaging also
AFP,
in tumor
LDH
marker.
and beta HCG we will repeat, sir.
Okay. On the basis of the imaging and tumor marker, we will categorize the international germ cell cancer cooperative group according to that.
Can you talk a little louder? Can you come near to the mic and talk?
Yes, sir. Yes, sir. After 4 weeks, sir, we will repeat the serum tumor marker, and on the basis of the tumor marker level, and we will decide the further management, sir.
So how will you decide on a tumor marker?
Already we have done a CECT, thorax, abdomen and pelvis, sir. In that there are multiple few lymph nodes were there, sir, which is of less than 2 centimeters. I designated as N1, and this is looking like a PT1 disease, sir. If the tumor markers are normal, S0, then
so what is S0, S1, S2, S3?
Sir, S0 is tumor markers fall within the normal limits, sir. S1 is LDH is less than 1.5 into normal, sir, which is units per liter, and HCG is milli international units per ml, sir, which is about less than 5,000, sir. S1 is, and AFP in nanogram per ml, sir, it is less than 1,000, sir. That is S1. And S2 is LDH is 1.5 to 10 into times the normal, sir. And beta HCG is 5,000 to 50,000, sir. And AFP is 1,000 to 10,000, sir. S3 is greater than 10 times the normal limit, sir, LDH. And beta HCG is more than 50,000. and AFP is more than 10,000, sir. I will categorize into if S0 or S1 markers are there. If it is a T1 and N1 disease, I will mark it as a stage 2A disease, sir.
So by this, what you are achieving?
Sir,
if
no, we will decide upon the management, sir. Depending upon the tumor markers, sir. If it is S0 or S1, our management will change, sir.
So tell us now how you are going to proceed.
If it is a tumor markers are if tumor markers are S0, if it is a T1 and N1 stage, we can keep the patient in the surveillance, sir. And we will repeat the investigation, CECT, thorax, abdomen, and pelvis after 7 to 8 weeks. If it is an S0.
yes, or if it's in the S1, then we will give the chemotherapy.
If it is an S1, we have an option, sir. As it is a mixed germ cell tumor, we can give chemotherapy or RPLND, sir, bilateral nerve sparing.
Okay.
Yeah, Ganesh, can you just take over?
You can answering from various scenarios. So HPR says classic. Sandeep, so when combined seminoma and non-seminoma, what do we say? So generally, mixed tumor comes here, technology. I mean terminology.
Yes, sir. Yes, sir.
When some literature also says that within NSGCT also, if it is a mixed, it's a combo of 2-3 subtypes.
Okay.
Pure yolk sac, less than 2% in the whole. Pure choreo. Again, that is very rare. So can you summarize अपना positive क्या है case में for the further?
So this is the young 35-year gentleman. He had the mixed germ cell tumor of the left testis with stage in the P1 and CN1 and tumor marker on the after the 4 week of the surgery. We need to the tumor marker value. Then S component we will come in.
So ये CN1 है, वो CN2 और CN3 क्या है?
So CN1 basically on the imaging, if there is the suggestive of the lymph node size is the less than 2 up to 2 centimeter, less than 2 centimeter, single
Right.
or multiple, and 2 is the 2 to 5 centimeter, single or multiple, and 3 is the more than 5 centimeters.
Okay. Okay.
So now, sir, this is the since the mixed germ cell tumor, and mostly the stage is the 2A, sir. So then we have the option of the first option is the chemotherapy. Second is the retroperitoneal lymph node dissection. But since the pathology report they are commenting on the only 2 components, seminoma and yolk sac. So we will prefer the giving the adjuvant chemotherapy, sir.
So basically, after this and looking at the CT, we'll do the CT chest also in this case. It is a CT abdomen pelvis showing retroperitoneal nodes. Am I right?
Yes, sir.
Yes, sir.
So वो एक miss मत करो please. After that, as you said, we stage or restratify, and you know how we restratify?
Yes.
How?
Yes, sir.
Uh,
Sir, there is the different
Stratification helps us to go at the treatment, right?
Yes, sir. Yes, sir.
Randomly chemo ऐसा होते नहीं.
No, yes, sir. So that's why, sir, we that as serum level after the 4 week of the surgery we needed, then we stratify.
I didn't hear. I'm sorry.
Yes,
Ganesh sir,
sir.
classical seminoma and yolk sac are the 2 components they have written in the histopathology report.
yes, sir.
So is it is such type of tumor should be treated like a NSGCT?
Sir, NSGCT only.
Yes, sir. Yes, sir.
Treatment
Definitely.
plan will go on NSGCT.
Yeah, because in spite of having a mixed classical seminoma is not of that much danger, and there is low lymphovascular invasion, which is one of the important prognostic factor for non-seminomatous tumor. Except
Yes,
the non-seminomatous tumor and lymph nodes are also present in CT. So should we treat such tumors like a NSGCT only?
Yes, sir.
yes, sir. Yes, sir.
Yes, sir. Not seminomatous germ cell.
Any non-seminomatous component present will take the whole treatment as a NSGCT.
Okay, thank you, sir.
So classical seminoma is one of the component. Yolk sac is another component, but surprisingly AFP is normal.
Yes, sir.
And they have given 30% yolk sac. So anyways, we have to believe this. That one.
No, that is why the two, it was again reviewed, na? And it showed
Yes,
the
sir.
same thing.
Right, sir. So we don't deny the pathology. I mean, whatever they have seen, they have reported.
Yeah. So now you had asked about the risk stratification. So let them talk about that.
They were talking. वही तो वो सुन रहा था मैं बोला नहीं बराबर.
Bhai, bolo.
Devraj,
For the risk
standard
stratification, we
advanced
need
germ cell tumors. How do we risk stratify?
sir, we will risk stratify both in the seminoma and non-seminoma. Non-seminoma is the poor, good risk factor and intermediate risk factor, and in the non-seminoma is the good, intermediate, and prognosis. In the seminoma, if the any that good are the any primary, either from the testis or the retroperitoneum, but tumor marker level is the less than that LDH level is the less than 1.5 times of the upper reference limit. But now, sir, recently that International Germ Cell Cancer Cooperative Group, they divided the group good into the two. One is the less than 2.5 LD, less than 2.5 upper reference level of the LDH and more than 2.5 because of the both of the different progression free survival and overall survival. And that poor that intermediate seminoma are they have been the non-pulmonary visceral mat with any primary or
intermediate
seminoma.
one with non-pulmonary visceral metastasis.
Yes, sir.
Any primary site in the sense testis or any midline.
And the non-seminoma, sir, there is a good prognostic are the either the mediastinal.
We call it good risk, intermediate risk, and poor risk.
Yeah, good risk. Good risk is the either this thing testicular or the mediastinal primary.
Testicular or retroperitoneal.
Testicular or the retroperitoneal primary with the
mediastinal primary goes straight forward to poor risk.
Yes, sir, poor risk only. With no non-regional lymph nodes or non-pulmonary basal mets and tumor marker, LDH is the up to the 1.5 times of the URL and alpha fetoprotein and beta HCG. Alpha fetoprotein is the third.
S1.
S1.
Yeah, S1. Yes, S1. In the intermediate is the S2 or and high risk are the either the mediastinal primary or S3 or this non-pulmonary visceral mat.
Where does your patient lie now? In NSGCT.
NSGCT, because of the we don't have the post-surgery serum tumor marker.
You didn't ask only. You straight away went to treatment, na? That is why when I stopped you and I said do a risk stratification as per advanced germ cell IGCCC.
No, sir, I told we have to do that after 4 weeks of the surgery serum tumor.
Who knows? He'll show you now what are the post
Sir, yes, sir.
Yeah, you should ask them.
Actually, patient was not following up, sir. At 6 months, the beta HCG was 1.20 and FP was 1.30, and at 9 months AFP was 3.48, sir. These were the two tests that actually patient was following up with the oncologist for chemotherapy after the surgery, sir. And these were the test reports, sir.
At 6 months directly we have. But at before orchidectomy also we had normal only, right?
Yes, sir.
Right. That LDH is the range, sir. I think 600.
LDH
After
is
orchidectomy, if with at least the experience which I see, I mean, after orchidectomy, that 300 whatever LDH is going to get to normal.
Yes, sir. Normal, sir.
So Devraj, say post orchidectomy, patient has not shared the tumor markers, but
Yes,
say
sir.
they were all probably S0, S1.
Yes, sir.
S0 पकड़ो तो क्या
S0.
तो कहाँ आता है
S0.
क्लासिफिकेशन वो बताओ अभी.
Yes, sir. So then it is the sir P1, CN1 and S0. This is the stage 2A, sir.
Stage 2A.
Yes.
Then what can we do?
We can do surveillance, sir, if it's stage 2A.
What we can do?
Sir, we
NSGCT
have the
2A.
sir. We have the both options. All three options, sir. In the surveillance, usually in the stage 2A, we will not do surveillance. Usually in the sir.
ये पक्का दोनों एक दूसरे को फोन करके डिसाइड करो कि क्या करना है.
Sir, surveillance usually we will do in the stage is 1A with low risk, sir.
वो बाद में पूछेंगे. अभी अपने पास स्टेज 2A का पेशेंट है, बराबर?
Yeah. Yes, sir.
सोचो.
So if it's stage 2A
Yeah.
S0.
So sir, yeah.
हाँ, क्या है? रोबोटिक सर्जरी करेंगे, बोलो.
So, sir, we have the option both. First is the adjuvant chemotherapy, and second is the retroperitoneal lymph node dissection. Usually, now the retroperitoneal lymph node dissection we will do if the HPR suggests of the teratomatous component, or there is the contraindication for the chemotherapy. So I will go for the adjuvant
जोर से
chemotherapy.
बराबर बोलना, मेरे को समझा नहीं है. कॉन्ट्रा इंडिकेशन ऑफ कीमोथेरेपी, उसको क्या करेंगे?
No, sorry, sir. Only mainly, sir, if the teratomatous component in the HPR, then we will go for the retroperitoneal lymph node dissection. Otherwise, we will
पता
go
चला
for the
टेराटोमेटस कंपोनेंट इन द रेट्रोपेरिटोनियम. वो कैसे पता चला विदाउट डूइंग रेट्रो क्या आरपीएलएनडी, वो बताओ. नहीं, whatever you said, can you repeat? मतलब I also didn't understand.
Sir, on the testicular HPR, there is a no teratomatous component on the HPR.
Correct.
Yeah.
So it
So
can
I
be
will.
like that, no, कि testicular HPR पे नहीं है, but अभी नोड थे ना अपने N1 नोड्स में, हो सकता है. Who knows?
Yes, sir. हो सकता है, sir.
बस. And we are anyways treating a mixed tumor NSGC like NSGCT.
Yes.
तो करेंगे क्या finally?
Sir, chemotherapy. I will give adjuvant chemotherapy.
Chemotherapy. संदीप क्या करेंगे?
Sir, if it is a 2A and marker is S0, I have two options, sir. One option is we can do a surveillance and a CT scan after 8 weeks. If it is a progressive disease, then I will go for chemotherapy, sir. No, if you are not going for a surveillance, I will go.
2B में कहाँ surveillance करते हैं?
What is wrong in doing a primary RPLND in this patient?
मतलब सर्वेलेंस कहाँ से आया? तुम लोग कीमो बोले एक्सेप्टेबल है, बट सर्वेलेंस कहाँ से आया?
If marker is negative, means not surveillance, sir. Follow up after 8 weeks, sir, with the CT scan.
ये किसका थ्योरी है? मतलब तुम बोले ना गाइडलाइंस कौन से पढ़ते हो, उसके कौन से गाइडलाइन का थ्योरी?
EAU, sir.
So
if it is if we can do, otherwise we can do a
listen.
sparing
Surveillance treatment is given for 2A in EAU.
Sir, follow up, not surveillance, sir. Follow up after 8 weeks, sir, with CE, CT scan, thorax, abdomen, and pelvis.
Already you have diagnosed it as a 2A. Already you have done the CT scan pre. Already you have done marker pre and post. Now it is 2A.
Yes, sir.
As per your diagnosis. So what is the treatment of 2A? That's what sir is asking. So in spite of wandering here and there, just you tell the treatment.
So 2A marker negative, I will go with nerve sparing RPLND or follow up scan after 8 weeks, sir.
Okay. So one treatment is 3 cycles of VEP. The other
Yes, sir.
treatment is to do RPL&D. If RPL&D you get anything positive, what will you do?
Then I will give BEP 2 cycles, sir.
2 cycles VEP. And what are the cure rates with either of these treatments?
The cure rate is the same nearly after the either the directly the
10%,
adjuvant
50%, 75%, कितना cure rate है expect करते हो?
70 to 90%, sir.
70 to 90.
Yes,
ये
sir.
random figure कहाँ से आया? Testicular cancer है भाई, cure rates are up to 98%.
Yes.
Post RPL&D, when will you observe the patient?
So post RPL&D, we will on the final HPR, we will on the see the HPR if there is a final HPR in the either is the PN1 or PN2 N3. If the PN1 is especially less than 2 centimeter and few lymph node, then we will observe the patients.
Few means how many?
Sir, less than 3, sir.
I feel it is less than 6. I exactly don't know, but sir, if I am wrong, please correct. Less than 6 and less than 2 centimeter.
किसमें
More than 5, we will consider N2, sir.
हाँ, more than 5 is N2. तो क्या discussion ये सुना नहीं है? I'm sorry.
Sir, when I asked the question when they will observe the patient post RPL&D.
Post chemo की RPL&D.
Post RPL&D.
अच्छा. So post RPL&D, if there is no tumor, then we observe. If there is tumor for this particular stage, then we give 2 cycles of BP.
Exactly. So
Chemo,
what I remember, it is either node negative or nodes are less than 6 nodes positive or less than 2 centimeter. In these two situations, we can observe the patient, and if it is more than 6 nodes and more than 2 centimeter, then adjuvant chemotherapy, that is remaining 2 cycle of BEP. If I'm not wrong,
if nodes positive आए तो मतलब standardly we give 2 cycles of chemotherapy. संदीप, तुम्हें पूछना है कि वो surveillance protocol में you said tumor markers normal. So in which situations tumor markers will be normal? What pathology you expect tumor marker to be normal for a lymph node?
After 2 years, sir.
हाँ, मतलब 2A is like I am having lymph nodes, right?
Yes,
15 millimeter or 18 millimeter lymph
Yes.
nodes I have. And
Yes.
still we get tumor markers normal after the orchidectomy.
Yes,
Correct?
sir. Yes, sir.
What will be there in that lymph node?
Teratoma,
Seminoma, sir. Mostly it will be seminoma, sir.
It will be either a teratoma or in some rare cases it is a choreo. But choreo also can give beta HCG. But in some pure choreos, lower, matlab non, it can be like tumor markers are normal. So your whole logic of that 8 weeks surveillance and then decide again with the imaging is because of these diagnoses.
Yes, sir.
So suppose this would have been a stage 1 NSGCT.
Stage 1 NSGs. Yes, sir.
What would be the treatment?
Same, sir. LVI is absent. And embryonal component is there, sir. Here more than 30%. So I will give a single AIS carboplatin AIS is undercover 7, sir. Single dose.
Okay. So the risk factors which you said, here it is different. I said stage 1 NSGCT, right?
Yes, sir.
yes, sir.
So either you identify the risk factors properly for NSGCT and seminoma. Seminoma, the main risk factor is the size criteria, above 4 centimeter.
Yes,
The
sir.
other
Yes,
criteria is ready testis.
Yes,
Yes, sir.
yes.
NSGCT, the criteria is what?
Embryonal component.
LBI and
Embryonal component above 40% or
Yes, sir.
30%.
yes, sir.
When you talk of NSGCT, we never talk of carboplatin. AUC7 dose carboplatin is for seminomas. Am I right?
Yes, sir.
Yes,
Yes,
yes.
sir. Yes.
I asked you about stage 1 NSGCT. So what is the treatment for stage 1?
One cycle of BEP, sir.
Yes, sir. Single cycle BP.
So all patients coming in, you will give 1 cycle of BEP, or there are some options?
Not all patients, sir. We will decide
embryonal
high risk or low
component
risk.
is
The
more, I will give 1
low
cycle
risk.
of BEP, sir.
ये दोनों ऑप्शन बोलो ना, मतलब if embryonal component is not more, if there is no LVM बोला है, ये theoretical discussion है, मुझे भी पता है. So what will happen? That you tell. क्या क्या कर सकते हैं? Stage 1 NSCCT, how will you treat?
Sir, stage 1 NAGCT on the basis of LB, SI and embryonal component, we will divide into the high risk and low risk. If low risk, then we will offer the both. First is the surveillance, second is the single cycle BEP. In the high risk, we will offer the single cycle BEP, sir.
ठीक है. So that is accepted answer.
Okay, fine. So Swastik, now what happened?
Sir, after this, the patient followed up after 1.5 years. Patient complained of severe left flank pain, and he was further evaluated.
One minute. Okay,
this-
so what I see, he landed up after 1.5 years. Okay, in between he was lost to follow up. Now he has got a pain on the left side. So what are the causes of pain on the left side in this case?
The pain and causes of this case, either that retroperitoneal lymph node mass that will be compressing the ureter or or infiltrating the Swas muscle or some. So they maybe have the pain due to that mass, sir.
So what we like to
Retroperitoneal
do?
mass. Sir, I will investigate the patient. I will do the CECT abdomen, pelvis, and thorax, sir, and also do the
Creatinine is
tumor
4.
markers. Yes, sir.
Creatinine is 4. Have you asked for that?
No, sir.
You are saying there is a lymph node mass infiltrating into the ureter, must be hydronephrosis.
Yes.
Have you asked for the
Creatinine.
creatinine?
No, sir.
Then
It's
So
a
Devraj,
creatinine is
what you can always do is, such a patient comes, you can have a general, nice, polite answer. I'll assess the patient. I will ask for tumor markers. I'll ask for routine investigations, and then I'll plan imaging.
Yes, sir.
When I say like that, the examiner, I'm giving him the last point to ask me, what imaging? So that is how you all can lead an exam. Matlab.
you understood how beautifully
Yes, sir.
Dr. Ganesh has explained you that you want to decrease the time also so that you can go further, because when you go further and go to the advanced treatment, you will get more marks. Okay,
Yes, sir.
fine. Okay,
Good.
Swastik, show them what happened.
Yes, sir. So, sir, the patient was evaluated and patient underwent a CT scan, sir. Ultrasound and CT scan was done. And these were the plates. So there are multiple plates. I have put 2 on one screen.
Okay.
संदीप और देवराज कुछ दिखता है तो प्लीज बात करो.
Okay,
Sir,
go
this
ahead.
is the lab.
Representative plates of CT, I think abdomen, pelvis है.
Yes, sir.
Okay, you want to comment on that? Any one of you?
Sir, towards the left side of the
Yes.
aorta,
The previous ones are left side of aorta. There is a heterogeneous.
क्या है left side of aorta?
The heterogeneous.
Heterogeneous. क्या है थोड़ा डिस्क्राइब करो, मेरे को नहीं दिख रहा किधर है.
वो previous slide में थोड़ा था.
First, just tell them the report.
रिपोर्ट बोल दो.
Yes, sir. So the conclusion of the report showed a large 6.3 into 4.4 centimeter well-defined hyperdense marginally enhancing lesion at the left para-aortic location in front of the left psoas and medial to the lower pole of left kidney. In addition to smaller, more dense nodular regions seen anterolaterally measuring 1.8 into 1.7 centimeter, suggestive of, in view of the patient history of testicular malignancy of metastatic necrotic para-aortic lymph nodes with differential possibilities, including retroperitoneal collection, abscess, or adjacent para-aortic lymph nodes.
ठीक है, बोलिए अभी क्या करेंगे.
Sir, we will do the CT chest also.
Okay, we do a CT chest. भाई CT chest है तो बोल दो.
First, क्या किया था उसका? कुछ है CT chest or something?
Yes, sir. So CT यही किया था sir. And then patient was put on a chemotherapy, sir.
Okay.
CT chest करना चाहिए था, मतलब किया रहेगा शायद. No medical oncologist will put on chemotherapy without doing that. No problem. किया रहेगा, मतलब it might be normal. Let us consider at least normal for the time being.
Yes.
Yeah. So after chemotherapy, what happened?
Sir, patient was followed up and patient underwent serial PET CT scan, sir. And on PET CT scan, a residual mass was seen, sir. 3 cycles of chemotherapy were done and BEP was given, and bleomycin was given on day 1, 8, and 15. And this was
Okay.
the yes, sir.
Now just tell them the report.
Yes, sir. So the first scan showed non-FDG PET avid, non-FDG avid necrotic enlarged lower left para-aortic nodes seen measuring out 2.1 into 2.1 centimeter. Fat planes with abdominal aorta were preserved, and posteriorly it focally abuts the left psoas muscle. So compared with the previous PET CT report dated 3/1/23, complete metabolic and significant morphologic resolution of left para-aortic node was noted, suggesting excellent response to the chemotherapy. Another was done, sir, later, and in this the PET CT report was 17 March, and then another was done, and an ill-defined distal bronchocentric opacity was seen in the left lung base, and so the current study showed no significant change, and another follow-up after 3 months can be done was suggested. So the mass was around 2 into 1.9 centimeters still, sir. The necrotic left para-aortic retroperitoneal lymph node was still 2 into 1.9 centimeter in size.
How apart were the two scans now, imaging wise?
Sir, in one was done in January, and another was one done in, sir, this one done in March.
Okay. So Sandeep, what is your opinion on the first and the second scan? What should have been done?
Sir, it is a mixed non-seminomatous tumor with residual mass of about more than 1 centimeter, sir, in the CT scan.
In the first CT scan only, right?
Sir?
In the first imaging sequence, post-chemo.
Yes, sir.
Then?
Ideally, I would, any residual mass in NSGCT, I will go ahead with the RP-LND, sir.
Okay. So what template of RP-LND you will do?
If I will do a left modified template, sir.
Any particular reason for doing modified and not complete?
Because it is a post in a salvage setting, sir.
There is a question in the chat. It is nice question. What about tumor markers post chemotherapy?
Asked tumor markers were normal, given as normal, sir.
Correct. Suppose tumor markers would not have been normal. What would have been done?
If tumor marker is the normal in the sense that disease is the responding, but tumor marker is the raging or the persistent, then we will go for the second line chemotherapy, not on the RPLND.
Okay, so you will go for a second line chemotherapy in that case. Correct.
Yes.
Okay.
Yeah. So Swastik, what was done?
Sir, retroperitoneal lymph node dissection was done, sir. Laparoscopically it was performed, sir.
Okay.
And the histopathology of the same was suggestive of
So Sandeep,
6
bilateral complete template में, what is the margins or the boundaries of the template?
Superiorly, the renal veins, sir. Inferiorly until the common iliacs. Laterally up to the ureter, sir.
Superiorly up to the ureter crossing common iliacs. अभी 3
Yes,
बार तो common iliac बोल रहे हैं. Common iliac has a length of 10 centimeter.
Yes, sir. Ureter crossing the common iliacs, sir.
ऐसा random नहीं रहता है.
Yes, sir.
Then superior and inferior हो गया. अभी क्या बीच में क्या रहता है?
Laterally up to ureter, sir. Laterally is ureter.
Ureter to ureter.
Yes, sir.
Okay.
Bilateral ureter.
Bilateral ureter. ठीक है. What is the concept for nerve sparing RPLND?
The concept for the nerve sparing RPLND basically to preserve that posterior sympathetic ganglion nerve, hypogastric plexus, and sympathetic chain to prevent the retrograde ejaculation.
Retrograde ejaculation.
Retrograde ejaculation.
ओके मतलब तुम्हारा कंसेप्ट ठीक है. तो 3 कंपोनेंट्स बोले वो भी ठीक है. थोड़ा सा पोस्ट गैंग्लियोनिक पैरासिम्पैथेटिक
Hypogastric plexus and
this is down post ganglionic parasympathetic L1 to
L3.
L3 and hypogastric plexus preserve both the sympathetic chains.
Yes, sir.
Okay. So where do you anatomically where these nerves come basically? Post ganglionic fibers come at which place? Suppose I am doing or you are doing the RPLND. So where will you start looking in the patient?
Anterior to the
anterior and lateral to the aorta, sir.
aorta, sir.
Anterior and lateral मतलब anterior and left lateral.
No.
Lateral मतलब left lateral ही होता है. अभी medial मतलब medial होता है.
Yes, sir. Yes, sir.
वहाँ कौन से नर्व जाते हैं lateral to the aorta? उधर तो सब नर्व टेम्परेट ही खत्म हो जाता है.
All along the
Post
anterior
ganglionic fibers
field
of the parasympathetic they start behind the IVC. So
yes, sir.
then they come into the interaortocaval region. They form a mesh where the fibrofatty lymphatic tissue is kind of embedded in that. So you probably dissect it nicely and then they come over the aorta, but the main trunks then go down towards the hypogastric plexus for the function which use it. And the hypogastric plexus typically would then go between Sandeep's 2 common iliacs.
Yes,
and
sir.
that is why usually we don't touch the tissue
Below the inferior
with
mesenteric.
the inverted V of the common iliacs because
Yes,
we'll mostly damage the hypogastrics. But if there is some large node or something sitting there, then we do remove it carefully or something like a berry picking or preserving the fibers and removing it. That is what we do. Normally it is not in the template. Okay, so see this report.
This report is
What
suggestive of the no residual disease.
all the nodes were negative.
All notes are the negative.
So how will you follow up the patient?
Sir, this
First
is the
year,
non-semi.
in non-seminar, sir, first year I will go every 3 monthly with the tumor markers, sir.
Okay, 3 monthly tumor markers. What about imaging or anything?
Imaging 6 monthly, sir, in the first year.
ये कहाँ से तो पढ़ रहा है ना क्या ऐसे randomly नहीं बोल रहा है ना?
No, sir.
Which imaging?
CECT, abdomen and pelvis, sir. We will do annually.
6 months करना है CECT.
In the first year.
तो यूरोपियन गाइडलाइंस पढ़ रहे हो उसमें क्या लिखा है बराबर बोलो.
Sir, in the first year, sir, 3 monthly clinical examination plus these things, clinical examination plus tumor marker, and 6 monthly, sir, 6 monthly is the CCT abdomen and pelvis and chest X-ray, sir.
ओके सो तुम्हारा सब नॉर्मल है, जो देवराज कर रहा है और जो संदीप बी कर रहा है वो, लेकिन किधर तो मतलब इमेजिंग पे नॉर्मल है, किधर तो बीटा एचसीजी नहीं एएफपी इज राइजिंग, तो क्या करेंगे तुम? कहाँ ढूंढेंगे उसको?
Sir, AFP rising, so then we will see the other cause of the raising AFP, like liver disease or sir, this.
Okay,
We
right.
will rule out non-malignant causes, sir.
Okay.
And we will now we will check for the contralateral testes and imaging, sir.
करेक्ट सो वो तुम भूल गए थे, कॉन्ट्रालैटरल टेस्टिस को भी थोड़ा सा देखना पड़ता है.
Yes, sir. Yes, sir.
Lateral
Sir,
testis
on
has
the
to be evaluated for any mass or microlithiasis,
Yes.
sonography करना पड़ता है, and examine भी करना पड़ता है when the patient comes to you in follow-up.
Yes.
yes, sir.
Contralateral testis के every evaluation was forgotten. That is why I asked that question.
Okay.
Fine. Okay. So Swastik, now what happened? Follow-up में.
So after this, post-operatively, patient developed a retroperitoneal collection, sir. And this was the scan, sir.
तो क्या किया? पिगटेल?
Yes, so the scan was suggestive of moderate size hypodense loculated fluid collection in the retroperitoneum in pre and paraortic regions, insinuating into the outer caval region with extravasation of excreted renal contrast medium from left mediator to fluid collection into the fluid collection. Features are suggestive of urinary leak with urinoma.
अरे बाप रे, urinoma.
So, and the creatinine was just equal to the serum creatinine levels. So it was more
Aspirated
like
fluid creatinine, you are saying?
yes, sir, yes, sir. Yes,
Yeah,
sir.
aspirated fluid. No, it was marginally raised by.
Marginally this, yes, sir. 1.2 and 0.9 was 0.9 was serum creatinine, 1.2 around was sir.
Sandeep, ऐसे situation में what options of treatment you think you should apply?
Sir, if I suspect a urinary leak, I will go with the left PCN, sir.
Left PCN.
Yes, sir.
Okay, how will that help?
First, I will drain the collection and I will do left PCN so that the left kidney will be drained and the serum creatinine and all. I will do all the investigations, sir. Then I will see the ureter where it is damaged, at which level it is damaged.
How will you see the ureter?
If serum creatinine is normal, I will do a IVP, sir.
In this, they are already showing leakage.
First,
They are showing that
there is a gross collection in the retroperitoneum, so we have to take care of collection as well as
Yes, sir.
the leakage.
Yes, sir.
So for the collection, you have to do a PCD.
Collection will do a pigtail, sir, for the kidney.
And for leakage, we have to do a PCD. That's what you have told correctly.
Yes, sir.
Okay. After with periodic sonography, we have to assess that. Is
Yes,
it
sir.
when it completely resolved, not resolved? Then serum creatinine, CBC, antibiotic, IV fluid if it is required.
Yes, sir.
And when it resolves completely, at that time we have to go for the site of search for the site of leakage.
Yes, sir.
So for that matter, if you want to go for CT or just a nephrostogram is also suffice.
Yeah, I think we can do a CT PCN gram.
Yes, sir.
That will be good investigation. And that will
yeah. So in this case, now one more thing is what we can do is this is what is one way of treating. Second is that you said very rightly, we drain this thing, we put the pigtail in the collection, and with a PCN, we do the degestanting.
We can do that. PCN plus
So clinically also we can see that what we do is we keep the drain for some time. Once it stops draining, after a few days, we clamp or we do nephrostogram and see whether there is any leakage or not. If there is no leakage, okay, then we wait for a few more days, keep it clamped, everything is fine, we can remove the nephrostomy.
We can do that.
So that is one way. Second way is, as Dr. Gite and Dr. Ganesh has said,
we can do the degestanting way also. There is can be done.
And then if later on you can put the digestant. But most of the time we have seen that after doing all these things, usually this leakage stops.
Okay.
Okay, now after doing all these things, patient has improved. How will you follow? How many years you will follow for the malignancy, and how will
5
you
years.
what you will do?
5
We will
years.
follow for.
Tell us.
Sir, we will follow up for the 5 years, sir. As we should for the first year is the for first 2 years, sir. The clinical examination, tumor markers are the every 3 monthly, and CT abdomen pelvis in the first year is the 6 monthly. Then at the 24 month, then at 3 year, then at the 5 year, and after the 2 year we will follow clinically, and tumor marker is the 6 monthly, and after 5 year, after 3 year, then annually, sir.
Because the maximum recurrence occurs in first 2 years only.
Yes, sir.
After
Within
that,
2 years.
recurrence is gone down. So the
Yes.
frequency of follow-up also decreased after 2 years. But
Yes, sir.
first 2 years we have to follow up very stringently
Yes, sir.
with whatever you are told.
Fine. So Ganesh, now anything else is left you want to ask?
Mute है sir, mute है.
So Sandeep, this patient was married or unmarried?
This patient is
Married.
unmarried, sir. Married and having
No,
married and having not
but
having
no
kids, sir.
child.
Sorry, sir. Married and having not having kids.
Okay. So in that evaluation, when sir asked you about वो routine investigations वगैरह ना शुरू में,
Yes,
Semen
sir.
analysis normal.
You have to do a semen analysis and cryopreservation, sir.
cryopreservation because he has no issues. ठीक है सर, बाकी कुछ नहीं है, मतलब ऐसा पूछ सकते हैं, मतलब व्हाट इज ट्रीटमेंट ऑफ स्टेज 1 सेमेनोमा?
आप कंप्लीट कर दो ना.
हाँ, तो
You come across so many different
what is
cases.
treatment of stage 1 seminoma?
Sir, stage 1 seminoma we will divide into two, the high risk and low risk, on the basis of the tumor size and involvement of the rete testis. If the
Okay.
tumor size less than 4 centimeter and not involving the rete testis, then it is the low risk, and more than 4 centimeter or involving rete testis, then it is the high risk. In the
Okay.
low risk, sir, we usually give the surveillance, sir. In the high risk, sir, we have the two options. Either we will give the
मुझे एक बताओ, ये अभी तुमने अच्छा बोला एकदम, बट सर्वेलेंस में क्या करते हैं, मतलब डॉक्टर, व्हाट विल यू डू इन सर्वेलेंस?
In the surveillance, we will routinely follow up the patient and take the clinical history, examination, sonography.
ऐसे टाइम पास मत बोलना. routinely follow up मतलब what is supposed to report to my OPD every 15 days or every 90 days or every 60 days?
Sir, every month, 1 month for the 1 year, then sir every 3 months for the second year.
तो every month में क्या करते हैं?
Sir, we will do the tumor marker and clinical
Monthly है
examination.
कि 2 monthly है seminoma में?
Yes, sir. Non-seminoma is the 1 monthly and seminoma 2 monthly.
तो क्या करेंगे फिर?
Sir, we will do clinical examination and you.
So apart from the low risk strata, everybody should remember to ask the patient and find out that if the patient is educated and having a supposedly going to have a good compliance.
Yes, sir. Compliance.
So remember these things about going for a just surveillance protocol. So where I feel that I am not going to get a compliance from a particular patient, I would still end up treating him like a high risk with what options? Tell me.
Sir, one option is the radiation therapy. Second option is the single agent carboplatin, sir.
Which is better and why?
Sir, usually that single agent carboplatin is the better because of the this thing.
This thing, matlab?
the long-term effects of radiation and the second malignancies after radiation were more, sir. So single-agent carboplatin is better.
So how many second malignancies after how many years of radiation are seen?
If it is more than 30 years, there will be a chance of increasing every year there will be increasing of 1.5% increase in risk, sir.
ना तो 50 साल का हो जाएगा तो उसको 75% मैलिग्नेंसी हो जाएगी.
There are some relative contraindication for radiation also, sir.
Relative contraindications for radiation.
Yes, sir.
मतलब
Like if patient having the inflammatory bowel disease and horseshoe kidney, these are the relative contraindication for the giving radiation to the patient.
okay.
And we will give the
Okay. So how mature is the data with AUC7? What is the longest follow-up data published?
that I don't know, but sir, that one study by Sionota or groups something.
So late studies are still not there, but it is considered that because of the late effects of radiation, the late
Yes.
effects of chemotherapy may be lesser. That is what
Yes,
we
sir.
consider. Okay.
Yes, sir.
चलो बस करें फिर.
Okay. He is present. One of the candidate has got a presentation. We will invite them in one of these lectures. I think that MCH people are having exams in June, July. Dr. Gite might be knowing. Dr. Gite, when is the exam? And DNB people have already got the date. That is in October, second
Yes,
week of
sir.
October.
बहुत दूर
So
है.
that is, yeah, but they are 4 months, so they are very busy. So most of them are now studying. So I'll ask in the group how often they want this teaching program, and then we will go accordingly.
Yes sir, tailor करेंगे. बिल्कुल.
Yeah. Because only 2 or 3 things are left. One is this thing CFNEs. That Dr. Bakshi, you only will have to manage, because in private we are not coming across many cases.
No problem.
So it's very difficult. So you select the cases like last time. You had a beautiful presentation. So that is one thing. And second is the reflux, you know. So these 2 things are mainly left. And then to practical things. So we'll see how to go about. We'll ask first all the students and then we will decide.
ठीक है sir.
Okay.
Good night.
Okay then. Good night.
Okay, sir. Good night.
Okay, sir.
Good night. Good night.